So I was discussant for abstract 4507, which was a randomized phase 2 trial comparing cisplatin and gemcitabine with or without berzosertib in patients with advanced urothelial carcinoma. This was presented by Dr. Monty Pao. This was a phase 2 trial randomizing patients to Gemcis, regular doses, versus Gemcis and berzosertib, which is a novel ATR inhibitor. The doses of Gemcis in the experimental arm were preemptively reduced to mitigate the myelosuppressive toxicity of berzosertib seen in phase 1 trials. The primary endpoint was progression-free survival. The study did not meet its primary endpoint. PFS was 8 months in both arms. The overall survival trends were worse with the experimental arm. Response rates were lower, and there was significantly higher myelosuppression seen with the triplet despite upfront dose reductions of gem and cis and ongoing dose reduction and discontinuation. And we've seen that the DDR pathway has shown to have prognostic and predictive significance in urothelial cancer, but use of PARP inhibitors has not panned out in urothelial cancer with 2 negative trials, the ATLAS trial and the BISCAY trial. And the conclusion for this abstract was that we should not compromise doses of cisplatin in urothelial cancer, and the DDR pathway is not a promising therapeutic target in this disease. The other abstract that I discussed was the abstract 4508, which was the long-term follow-up from the Keynote 052 phase 2 trial of pembrolizumab first line in cisplatin ineligible patients with advanced urothelial cancer, presented by Dr. Peter O'Donnell. Now, we have come a long way for first line treatment in cisplatin ineligible urothelial cancer since 2017. We only had gem-carbo initially available for these patients, and then in April and May of 2017, Atezo and Pembro were approved as single agent for these patient population based on the remarkable duration of response and survival estimates. But in June of 2018, FDA had restricted the use of these agents only to patients who had high PD-L1 expressing tumors or who were not deemed candidates for any platinums. And now, last year, we saw that platinum-based chemotherapy followed by maintenance Avelumab for those who do not progress improves survival, and that has become our new standard. We have also seen the data from the confirmatory 361, Keynote 361 trial, which was the confirmatory trial for Keynote 052. So in terms of discussing this abstract, the primary endpoint was objective response rates. And when I compared that to Keynote 361, we saw that patients, even with high CPS scores, pembrolizumab was associated with lower response rates than gem-carbo in both total patients as well as high CPS score. So PD-L1 did not appear to be a predictive biomarker. Response rates were 16% lower with pembro compared to gem-carbo. And there were early deaths on the pembro arm in the confirmatory 361 trial. Eventually, the curves caught up, but did not cross significantly for a positive trial. And durability of response was really remarkable with pembrolizumab, both in Keynote 052 and the confirmatory Keynote 361 trial. It was not reached compared to 6 to 8 months with gem-carbo. And my takeaway was that what we have now learned in this setting, that pembrolizumab had lower response rates and early deaths compared to gem-carbo, and PD-L1 does not seem to predict responses to pembro, and that Avelumab maintenance has shown improved survival. And the control arm in the confirmatory trial was just chemo, not maintenance immunotherapy, and still the pembro did not outperform it. I would say that we should use pembrolizumab in patients with locally advanced and metastatic urothelial cancer who are not deemed eligible for even carboplatin. And these are around 10% of such patients we see in our practice who are not fit enough for carboplatin either. An abstract 4519 was presented by Dr. Arjun Balar, a first-in-human trial of inducible T-cell co-stimulatory, that is ICOS receptor agonist, Feladilimab, alone or in combination with pembrolizumab. And the trial was called INDUCE-1. And ICOS is a novel immunostimulatory and immunosuppressive target in a variety of cancers. And Feladilimab is a first-in-class humanized IgG4 monoclonal antibody. It's an agonist. This was a first-in-human trial, so numbers were limited. In Part 1B, it was only Feladilimab monotherapy in PD-L1 experienced patients. 14 patients were enrolled. Part 2B was PD-L1 naive patients. 32 patients were enrolled. And it was combined with pembrolizumab. Primary endpoints were safety, PK/PD. Efficacy was a secondary endpoint. It seems that the monotherapy and the combination arms were really very well tolerated, mostly grade 1 to 2 adverse events, nothing major. And in terms of efficacy, it's too small a subset to draw conclusions, but PD-L1 did not correlate with responses either to combination or single agent, while ICOS positive tumors, patients did respond better and had that longer duration of response. But we need phase 2 randomized trials to further explore the role of this agent. And the key takeaways from our discussion were that when possible, we should try to treat patients with first-line platinums, followed by Avelumab maintenance if they do not progress, and if they progress, to use any approved checkpoint inhibitor. And upon further progression, there's a variety of options now available, like erdafitinib, enfortumab vedotin, and sacituzumab govitecan. And in platinum-ineligible patients, we can use single-agent pembro or atezo, as was shown in the studies.